Am I audible?
Yes, sir.
Yes, sir.
Okay. So, just a moment. So, today we will discuss about the diabetes mellitus. Today's topic of discussion is diabetes. Okay. You have to deal with this diabetes patient and diabetes topic not only for your exam but throughout your life. You have to see this patient day in and out in your family members, in your neighborhood, everywhere. Even after you are doing your post graduation in some surgery, gynecology, neurosurgery, you have to deal with this patient because these are everyday. Okay. So whenever you get time, you read it thoroughly, and these topics will be completely covered. So today we will discuss about the. If you have doubt, please you can stop me and ask me very long. So about diabetes mellitus, today we will discuss about pathogenesis, diagnosis, and management. Its complication and management of the complication we will deal it in other classes and some other topics. Okay. So diabetes mellitus, it is a group of metabolic disease characterized by hyperglycemia. The key word is hyperglycemia here, which results from defect in insulin secretion or insulin action, either of these or both of these. Okay. This insulin is secreted from beta cells of pancreas, our pancreas gland. If there is a defect in this secretion or section, it will lead to hyperglycemia, which will lead to the disease diabetes mellitus. So, depending upon the etiology of this diabetes, the factor contributing for hyperglycemia will include either there will be reduced insulin secretion, decreased glucose utilization, or and increased glucose production. Okay, either of these. So, we will proceed to the classification of the diabetes mellitus, its etiological classification. It tells about its pathogenesis also, etiology and its pathogenesis. So this table is directly taken from the Harrison 20th edition. You can get it complete, you can get this table directly from there. But just to summarize here, we will see some gist of this table. The first is the type 1 diabetes. Its pathogenesis is an immune-mediated beta cell destruction. This diabetes patient are usually young age patient of around 10 to 14 years. We will see in the next slide. There will be some immune-mediated destruction of the beta cells of the pancreas, which will lead to the absolute insulin deficiency, because these beta cells normally secrete the insulin. Okay. So this is the type 1 diabetes. It contributes around 5 to 10% of the total diabetes patient. The next one is type 2 diabetes. This type 2 diabetes, can you see the slide? So now the second is type 2 diabetes. This is the major chunk of the patient. Most of the patient are type 2 diabetes, which you see every time in your surrounding, your parents, your relatives, elderly patients are most of this type 2 diabetes only. So these may range from predominantly due to insulin resistance with secretive insulin deficiency to predominantly insulin secretory defect with insulin resistance. Means in type 2 diabetes, there is some amount of insulin resistance will be there. The insulin amount may be adequate, but it is usually resistant. We will discuss it later in next slide. Another is the third one is the gestational diabetes mellitus. These patients are usually non-diabetic, but during their pregnancy and gestational period, they are found to be hyperglycemic. They are labeled as gestational diabetes mellitus, and they are prone to turn out to type 2 diabetes later on in their life after a few years. Okay, we will discuss it also in the other slide. These three are the common one: type 1, type 2, gestational diabetes. Now there are some specific type of diabetes. You can go this table thoroughly from your textbook, but we'll just discuss few headings only. Now, special type of diabetes there's some type of genetic defect in beta cell development, and its mutation occurs. So it leads to maturity on diabetes of young, MODY, or which is a body type 1, type 2, type 3. Okay, this will lead to maturity onset diabetes of young. And similar, these are some very rare cases which we do not see it regularly in our clinics, but it can be present anytime. Okay. Then besides this genetic defect, another can be transcendental diabetes. There's some disease of exocrine pancreas, genetic defect in insulin action. Then some endocrinopathies like acromegaly, Cushing syndrome. These are some special type of diabetes. These are some associated diseases uh, glucogenoma, pheochromocytoma. This patient also present with diabetes mellitus. Okay. Some drug can lead to diabetes mellitus like steroid glucocorticoid, which we use frequently. Okay. So this can lead to diabetes mellitus. Some thiazides, beta agonist. Okay. So some drugs you have to remember. Now, this diabetes, some infection can lead to diabetes, like congenital cytomegalovirus, Coxsackie. This can lead to diabetes mellitus. So, major is type 1, type 2, gestational, and these are some rare type specific. Out of this, type 2 is most important. We will deal with one by one. Okay. So, before proceeding, first the classical symptoms of the diabetes. First is polyuria. Patient passes large amount of urine, excessive urine, polydipsia, excessive thirst is there. Patient will drink excessive water. So there can be polyphagia also. Then this patient present with recent weight loss. When the symptoms start, there will be some weight loss will be present. There will be blurring of vision, and this diabetes patient are prone to infection. Overall, all infection, they are prone to other infection regarding to the level of the blood sugar they have, but genital infection is most common. Genital infection in women is vulvovaginitis or urinary tract infection. Patient come with this urinary tract infection later turn out to be on investigation they are found to be having diabetes mellitus, high blood sugar, because this blood sugar leaks through the urine, and this blood sugar which accumulates in the periurethral area. They are culture medium for this organism like bacteria, various fungus. So melanoposthitis in men, and vulvovaginitis in women. These are presentation of some patients. Okay. So what's type 1 diabetes? It is also known as insulin dependent diabetes mellitus. Although this term is obsolete now, but they are insulin dependent. Earlier, type 1 was known as insulin dependent, and type 2 is known as non-insulin dependent. Okay. So type 1 is insulin dependent diabetes mellitus. It is also known as juvenile diabetes. The age of presentation. These are quite young patients of the age group 10 to 14 years. These young children are diabetics, and this is mainly due to causes due to 90% is due to autoimmune related. Okay, and 10% is idiopathic. Out of total diabetes patient, they contribute of only 5 to 10%. Okay. Any doubt till now? Am I audible? Are you there? Hello?
Yes, sir.
Yes, sir.
Sir.
Any doubt till now?
No, sir.
Okay, wait a second. Second is type 2 diabetes mellitus. So this is the major amount of patient which you will see. These are 90 to 95% of patient. Okay, this is non-insulin dependent. This age group is usually adult and elderly people. Okay, usually more than 40s, 35, 40s. Above this age, you will find this type 2 diabetes mellitus. They begin as insulin resistance. They have a good amount of insulin in their body, but this insulin are resistant. So to compensate the need of insulin, insulin rises. Okay. So gradually the pancreas loses its ability to produce insulin. At one point, the pancreas will gradually increase the amount of insulin production, then it will lose it, and later on there will be insulin deficiency also there. Okay. But insulin resistance, it begins with the insulin resistance. Now, risk factor for type 2 diabetes, as you can see, most of the patient, 90 to 95% are of type 2. So we will see a little bit detail of this type. Group is usually more than 45. Even you can see nowadays 30, 35 is also common. But usually in the epidemiology we see that its group of presentation will be more than 45 years. These are obese type of patient, overweight patient with BMI more than 25, They will have some background disease or family history of diabetes. Their parents would be diabetic. Either of the parents or both of the parents would be having diabetic with a sedentary lifestyle, physical inactivity. Previously, they would have any impaired fasting glucose or impaired glucose tolerance test. They could have the history of the females could have the history of gestational diabetes mellitus or delivery of large baby like more than 4 kg. They will have comorbidity like hypertension, or their HDL cholesterol would be less than 35 or triglyceride more than 250. Some female obese patient, obese girls, used to suffer from polycystic ovarian syndrome. They are also prone to become type 2 diabetes mellitus. And other diseases like coronary artery disease and ischemic stroke, any other vascular disease, they are all having risk of later acquiring this type 2 diabetes mellitus. Gestational diabetes, as I told, it is a condition of glucose intolerance diagnosed in some women during pregnancy. Before pregnancy, they were normal, but during pregnancy, some amount of glucose intolerance is diagnosed. They are known as gestational diabetes. Epidemiology it is found everywhere, but in all over the world, but it is more common in African Indians. Okay, these are obese patient, obese female, or with a family history of diabetes. So after pregnancy, usually they become normal, they become non-diabetic, but 5 to 10% of this gestational diabetes will turn into type 2 diabetes mellitus. So we will go proceed to the diagnosis of this diabetic patient. Diagnostic criteria will be discussed in this. We will discuss criteria, and this is ADA and WHO classifications are given. ADA is American Diabetes Association classification, and WHO, I think all of you know, World Health Organization. So that is normal glucose level, normoglycemia. It is slight difference is there as per the definition, but more or less it is equal. Fasting is less than 100 in ADA, and in WHO it is less than 110. To our post-prandial glucose, to our post-lunch or post-meal glucose is to our plasma glucose is less than 140 normal in both of them. Then fasting more than 100 to 126 and in WHO more than 110 to 126 is known as impaired fasting glucose. If someone goes and measures his fasting glucose, it comes around something 115, 120. He is neither normal, he is neither diabetic. It is known as impaired fasting glucose. Okay, this is the for fasting, and similarly there is range for to our post lunch. Okay, to post prandial. So impaired glucose tolerance. What is impaired glucose tolerance? To our post plasma glucose to our post lunch or post prandial. If it is between 140 to 200, it is known as impaired glucose tolerance. This cannot be labeled as diabetes. They cannot be labeled as normal. Okay. So this is the range of impaired fasting glucose and impaired glucose tolerance. Now we will come for the diagnosis of the diabetes. So as per ADA, it is more than as per ADA and as per both WHO classification. Fasting plasma glucose more than equal to 126. Okay, more than equal to 126 of fasting is diabetes, or to our postprandial more than 200 is diabetes as per both the classification. And another one criteria, it is not mentioned here, is HbA1c level more than 6.5. Okay, either of these three can be labeled as, any one of the three can be labeled as diabetes mellitus. So some just knowledge about the impaired fasting glucose and impaired glucose tolerance. It is an intermediate form between the normal and between the diabetes, and it is a natural history of diabetes. Its incidence is around 10 to 15%. For the first glucose abnormality, the patient will develop only postprandial glucose. Okay, first postprandial will develop, then later on impaired fasting glucose will be developed. And postprandial glucose has higher sensitivity for predicting progression to diabetes mellitus than impaired fasting glucose. Now, again, postprandial is more important as compared to the fasting for the diagnosis purpose, okay, for the progression purpose, and they are also associated with the cardiovascular disease outcome. Okay. Here for diagnosis of diabetes, again it is the same thing. Classical symptoms of the diabetes, which I have told you before, and with plasma glucose more than 200. Casual plasma means random plasma glucose. It can be labeled as diabetes. Second, fasting plasma glucose more than 126. What is fasting? Fasting is defined as no calorie intake for at least 8 hours, or overnight fasting. What we say, we take meal at night and we take blood sugar at morning. Okay. store plasma glucose more than 200 during oral glucose tolerance. It is important. It is during an oral glucose tolerance test. By definition, it is OGTT. We in routine clinics we said postprandial, but for by definition, it is store plasma glucose more than 200 during an OGTT. What is OGTT? Oral glucose tolerance test. How it is done? Using a glucose load containing 75 gram of anhydrous glucose dissolved in water. We do this much 75 gram of glucose and check the blood sugar after 2 hours. If it is more than 200, then it can be labeled as diabetes. It will be labeled as okay. So how to do this glucose tolerance test? Normal diet for last 3 days, overnight fasting, blood sample for fasting glucose, then 75 gram of glucose in 300 ml of water to drink over 5 minutes. That blood sample will be taken over after the intake of glucose. There should not be stop any smoking or recent smoking. Patient should be free from stress because this can also lead to hyperglycemia. And 6 weeks from that, there should not be any significant medical illness. Okay. So when we will treat the patient, we have to set some parameters. So how much should be our target blood glucose level for a diabetes patient? So glycemic goal for an adult with diabetes mellitus. So 3 parameters we will see: fasting, postprandial, and HbA1c. So what is AAC? American Association of Clinical Endocrinology, and ADS, American Diabetes Association. They have given just a slight different, slight different between the two. HbA1c target level should be less than 6.5 here, and in AAC and in ADA it is less than 7. Fasting is less than 110. More or less, it is similar range, but some difference is there. In postprandial AAC, it is less than 140, and ADA it is 180. We follow ADA. It is a less strict one, and it is followed more worldwide. Okay, American Diabetes Association guidelines, even for the diagnosis and even for the treatment goals. Okay. In non-diabetes, increased HbA1c associated with significant increases of cardiovascular and cerebrovascular disease. Patient will need to have the risk factor of developing coronary artery disease, and they need to have hemiplegia, cerebrovascular disease. Okay, if the patient is having high HbA1c level. So target is there to keep it under the strict control. We will proceed to the management of this diabetes. Till now, any doubt? So till now we have discussed about its definition, its pathogenesis classification, and its diagnostic criteria. Any doubt? Can we proceed? Okay. So we will go to management. Okay. So management first we have to. It is done under mainly 3 headings: medical nutrition therapy, oral hypoglycemic agents, and insulin therapy. First, we will try to treat the patient by their nutrition and lifestyle behavior. Okay. So first, we will treat it with the MNT. MNT is medical nutrition therapy. Obese patients are advised to lose weight. Okay. Sedentary patients having sedentary lifestyle are advised to do regular physical activity, behavior modification to lose their weight. Their diets are modified. Advised to take low-fat diets, low-carbohydrate diets. Okay. And this is a part of medical nutrition therapy. We will proceed. Here you can see, this is just chart of showing the lifestyle therapy. Left border you can see in green. You can see what headings we control this. Main nutrition. There should be they should maintain optimal weight. In diet there should be calorie restriction. Plant-based diet are promoted. Okay, all the diets are avoided. And physical activity, it is very important. All diabetes patients are advised to take physical activity 150 minutes per week. Moderate exertion. Moderate exertion means walking or just stair climb. Every 150 minutes per week. Okay. It can be done every day throughout the week or 5 days per week. Another proper sleep, behavior support, and smoking cessation. These are the type of medical nutrition therapy and lifestyle therapy. Here, mainly nutrition and physical activity, it is the most important one. Then we proceed to OHA, oral drugs, oral hypoglycemic, anti-hyperglycemic therapy, oral hypoglycemic therapy. Okay. So this is the chart how we proceed. Later I will tell about the classification. This is the chart how to proceed. First, you can see first we start with the lifestyle changes. You can see for healthy, we promote for healthy eating, weight control, increase physical activity, and diabetes education. If patient is under control, it's okay. Otherwise, we proceed with the drugs. We proceed with a single drug, which is known as metformin. Okay. Then we proceed with we add second drug, well therapy, along with the metformin. We add any second group of drug. And we will tell about the classification of drug in the further slides. If patient is not under control, even after 3 months of doing this drug therapy, we have to proceed. We have to add on for third drug. So patient will have 3 different group of antidiabetic drugs. Yeah. Metformin, second group can be either sulfonylurea, then will again the third group like or GLP-1. Okay. Even after this triple therapy, patient is not under control. Then after taking this triple therapy for around 3 to 4 months, we proceed for insulin injectables. Okay. This is the just how we do our management. This is the gist of the complete treatment. We will see in details in further slides. Another important thing is that what about if the patient is having hypertension along with the diabetes? So if the patient is having hypertension or not having even hypertension, his routine blood pressure should be checked in every visit. Measure blood pressure at every routine diabetes visit. Okay. If patient is having systolic pressure more than 130 and diastolic more than 80, then confirm it on separate day. You have to confirm that there is hypertension is present or not, and accordingly you have to start the treatment. Okay. You have to again check, confirm it on separate day, a separate operation. Again, it is the same thing which we have discussed. First, we will diagnose the patient. After diagnosis, we will first lifestyle intervention will be done, like diet modification, physical activity, behavior modification. Okay. And we will get first line drug, that is metformin. If the HbA1c level, which is glycated hemoglobin level, this comes under control, it's less than 7, then we can keep the patient here. If it is more than 7, then we have to add another drug. Okay. You can add directly, you can go to add insulin or injectable, or you can add second line sulfonylurea, or you can add any other drug. Okay. How this, what are the mechanism of action and site of action of this oral hypoglycemic agent? So regarding the mechanism of action, you have to see, I will tell you. Now first see here the site of action of this oral hypoglycemic agent or oral anti-hyperglycemic agent. Okay. Anti-hyperglycemic or hypoglycemic agent. First is alpha glucosidase inhibitor, like the farbose. Okay. So this act in the stomach, where we take our food. It is taken along with the food. It is an glucosidase inhibitor. What it does, it prevents the breakdown of carbohydrate to glucose. It is a glucosidase inhibitor. It will prevent the production of glucose through our body. Okay. Second is insulin secretive. It will act in the pancreas. It will promote the secretion of insulin. Biguanides like metformin, which is the main drug. It acts at several places, but liver is the main center of action. And another drug like thiazolidinediones act at muscles and adipose tissue, peripheral tissues. So different drugs have different site of action. Okay, so we will proceed to the next slide. First drug is sulfonylurea. You can see what are the sulfonylurea we use. First you can see the name glutamide, second glibenclamide, third is gliclazide, and glipizide and glimepiride. Okay, these are the drugs under sulfonylurea. Okay. So below name details are the brand name, like you can see Restinol, you can see Emerit. These are the brand name of this drug. So these are the group. Everyone should read the classification of this OHA, all the oral hypoglycemic agent, its classification, every drugs, every side effect. So this sulfonylurea risk, what are the risk factors, side effects of this? They can lead to hypoglycemia. This oral drugs can lead to falling the blood sugar below the normal range. They can lead to hypoglycemia. They can lead to weight gain. Okay. So there is side effect of weight gain. We usually prefer this for thin build patient, very thin patient, not for obese patient. We prefer this for thin patient because side effect is very good. Now, where is the group? In the right corner, you can see the drug class, and in the left corner, you will see the drug names. So, like first is biguanides. Biguanides, there are drugs like metformin. You can see metformin. Another drug is fenformin. Fenformin is banned because of its major side effect, lactic acidosis. Metformin also causes lactic acidosis, but its incidence is very low as compared to the fenformin. So, but earlier fenformin was also used, but till and now, at present, it is totally banned. Metformin is the first line drug, as I have told you. You can see other side effects like dyspepsia, diarrhea, lactic acidosis. These are the side effects of these bicarbonate. Second drug class is alpha glucosidase inhibitor. As I have told already, it's drugs come like carboys. Okay. I think the spelling mistake is there in this slide, but you can check it. Side effect like as it what it does, it inhibits the destruction of carbohydrate to glucose. So more amount of carbohydrate are present in your intestine and your stomach, and it will lead to fermentation, it will lead to formation of gas. So there will be gas production, abdominal pain, and diarrhea. These are the side effects of alpha glucosidase inhibitor. Another group is thiazolidine. Its drugs its examples are rosiglitazone, pioglitazone. Okay. Rosiglitazone, pioglitazone. Its side effects are edema, weight gain, hepatic failure. Last one is meglitinides, like repaglinide, another is nateglinide. Its side effects are weight gain and hypoglycemia. These are the oral drugs. Till now it's okay. Okay. Any problem? So we will proceed.
No, sir.
Okay, so we will proceed. Now we have done two methods of management. First is the medical nutrition therapy or lifestyle modification. Second is the oral drugs. If the patient is not even controlling both this method, then we will have to add injectables, insulins. Okay, insulins are given. These drugs are given usually subcutaneous. IV also in some special cases, but this is given at subcutaneous. So treatment with insulin does not have to be permanent. First, once the patient is started insulin, he will take insulin throughout life. It is not like that. Okay, does not have to be permanent. It is very safe and effective treatment. Why? Because diabetes is a state of insulin deficiency, and what we have to replace is insulin. So even in the future and at present also, insulin is becoming more or less the first line drug. Okay, along with the metformin. There are lots of insulin is there. We will discuss in the next slide. What are the options, different options? We have to look for the cost and duration of action, everything. Then one thing should be kept in mind always while giving insulin, and always for the before prescribing insulin, that is its important side effect is hypoglycemia. So once the patient takes insulin, he will definitely his blood sugar will come, even if it is normal, even if it is high. So it's a major side effect. So usually these are life-threatening condition can develop into hypoglycemia. Patient can collapse, patient can die due to hypoglycemia. Due to overuse of insulin, if there is severe hypoglycemia for prolonged duration, there can be brain damage. Patient can go into medication. It can lead to death. So do not be over-aggressive. Okay. Do not be over-aggressive in giving insulin or treatment. What the physician for us. And as it results in hypoglycemia, it is a very important side effect that we also follow. Now, sites of insulin injection. I think for most of you know this. If you don't know, just take a look here. The periumbilical area. In the ward question, definitely you have seen some sister giving some insulin to some patient. Different surgery wards or cabin wards, so you can see that. So the most common site is the periumbilical area. You can see in the first image. And below you can also give it in the lateral aspect of the thigh, in the arm, and in gluteal region as well. Okay. These are the subcutaneous injection. Technique first, just to show you, although at most setup sister used to do the nurses are there to do this, but every doctor should know, and every doctor should know how to give, where to give, when to give. Okay. So first you can see in the slide that there is a drop. You can see a drop is removed. So air should be removed from the syringe. Then in the second picture you can see you have to pinch the skin so that the subcutaneous tissue becomes prominent. Then you have to move the little vertical at the 90 degree. Okay. This is like you can see in the periumbilical area. Insulin is being given on the lateral aspect of the thigh. we will further proceed to the type of insulin. Okay, this will end in next 10 to 15 minutes. So, I think so. It's okay, no? Speed is okay, or I have to slow down? Okay. Then, so we will further discuss about the type of insulin. It's pharmacokinetics. Basically, two types of insulin is available as a plotted classification. I say first is the basal insulin, and second another will be the short acting, or another will be the meal related insulin. Okay. So basal insulin is not related to meal. What it does, it suppresses, you can see the pharmacokinetics, so it is written here. It suppresses hepatic glucose production. The glucose which is produced in the liver, it suppresses that and maintain near normal glycemic level in fasting state. Okay. So its type are NPH, glargine, and retinol. These are the three types. Everyone should know the classification. Definitely, you read it in second year. Everyone knows the classification of OHA and insulin, everything. But again, you should read it again and do it by heart. Its onset, its peak, and duration, everything. Every insulin, every type, and onset, and duration, and side effects of all oral hypoglycemic agent. It is very, very important. Even if you become an physiologist or pathologist, you should know this, because before that you are a doctor, MBBS doctor, so everyone should know this. And this is very common disease you will see everywhere. You will be asked that question from your relatives, neighbors throughout your life. Someone will ask you every day this question or side effect or dose. So you should know. So type of basal insulin are NPH, glargine, and retinol. You can say I have written here onset, peak, and duration. These are long-acting insulin. You can see its duration is around 12 hours, 24 hours. So there is a level of insulin is maintained throughout 24 hours. So what happens? There is no peak. Okay. So it maintains the fasting level. So here, like sleeping hour. What is the breakfast, lunch? Okay, snacks, sleeping hours. Okay. It is usually given at the sleeping hours, and pH has just a peak, and it does not have peak. It maintains at a level. Another is glargine and retinol. Okay, it maintains insulin level at a constant, we can say serum level, so that there is no peak. So it does not usually this long-acting insulin like glargine retinol does not cause hypoglycemia, which is the important risk factor. Unless the exposure is very high, it will not cause hypoglycemia. Nutritional insulin. These are meal related. You have to take this insulin with the food. So if you insulin, then patient have to take the food. And it means we have to do it before breakfast, before lunch, or before dinner. They should be ready, prepared, and kept in front of the patient. Then we give the insulin and patient takes the food. Why? Because you can see here, there are four types you can see. Types of insulin are regular insulin, and another three are lispro, aspart, and prolactin. Onset of action is very short. Okay, once you give the insulin, within 5 to 15 minutes, every insulin action will start and peak in next 1 hour. So if this is given without meal, patient will become hypoglycemic. So it should be given always with the food. Its duration lasts for 4 to 6 hours, as you can see in the chart. So these are the important type of meal-related insulin: lispro, aspart, prolactin, regular insulin. With the graph, I have tried to explain it how it is given. B is breakfast, lunch, B is snacks, sleep and hours. Okay. So NPH you see that is long-acting insulin. Okay, usually given at night, morning, or at night, not related with the meal. And you can see RI, rapid acting analog, like lispro, aspart, prolactin. These are given along with the meal at the time of breakfast, at the time of lunch, okay, at the time of dinner, at the meal snacks. Okay, you can do it like that with the meal. Here, these are the long-acting glargine retinol. This is usually given at sleeping hours. They maintain a serum level. There is no peak of this, as it is present in short-acting. It maintains throughout. It controls the fasting glucose. Okay, it is any doubt you can ask me. So okay.